blueprint the next time, and you guys are like, oh, again.
All right, so you are now live.
Kevin Flynn wanted to come up really quickly and steal the show for a moment.
Which seems hard for an Irishman to do that. My name is Kevin Flynn. I'm Vice President for Mission and Ethics, and on behalf of my mission boss and system ethicist, Sue Belanger, thank you for being here. I want you to know how very welcome you are. And I have been in healthcare for 40 years, and one thing I've learned is physicians love to brag about how talented their kids are. So here's a chance to prove it. Saturday, December 4th, from 11 a.m. to 3 p.m., we're having Christmas around the world in the atrium. Santa will be there, but it's a multicultural event. So whatever your background or culture, if your kids are talented at singing, dancing, playing an instrument, parkour, I don't know, Shakespeare, soliloquies, whatever they're good at, just contact me via email or Rosemary Ford. She's really coordinating this. We really want to pack those 4 hours with the talent of children of St. Joseph Hospital employees and our faculty. So thank you very much. That's all I have.
And I wanted to say thank you and welcome to our Grand Rounds presentation. Most especially, I wanted to welcome our panel. I was just speaking to them about how much courage it takes for all of us to be our true selves in everyday life. And I think some of us don't do it as well as others, but I think it takes a lot of courage to live your true self and whatever that means to you. And I appreciate the fact that they're willing to come talk to us about how their life has been, how their journey has been shaped by who they are. And I started to think about my own lack of knowledge in the LGBTQ world, and I've interacted with lots of patients who are part of that world, and realized that I don't know what I'm doing. I use the wrong pronouns. I try really hard, and I tell my patients I'm trying, and if I mess up, please correct me and understand that I'm trying. But it is always hard to relate when it's something other than what you know. So I thought, what better way to correct my own lack of knowledge, but to bring some professionals in who can help educate me and my colleagues on how we can do this better. I think also there are some specific LGBTQ health concerns that we don't learn about in medical school that are very salient and need to be addressed. And as we all know in healthcare, it's a constant learning process, and we're constantly trying to better ourselves, not just in how we deal with people, but also our knowledge base. We need to continue to learn. So I, through a mutual friend, was connected with Erica, and I'm so glad that I was, because she's an amazing person. She is very open and very approachable and very tolerant of people like me who are ignorant to the ways of the world sometimes. And I certainly used the wrong pronoun once or twice, and she forgave me. Erica has been a Nashville resident for more than 40 years. She's the proud parent of 3, she says young adult children, but I think they're in their 30s. I would say they're adults, 20s and 30s. And about 3 years ago, she embraced her trans femme identity. And she has a very interesting past. She's kind of been through all walks of life, done all sorts of things I wish I could put on my resume because they sound really fun. She's been a musical, or she still is, I'm using past tense, but she in the past and continues to be, has been a musical performer. She's done some acting in theater, film, and TV. She's a director and producer for some feature films, has won some awards nationally for her films. She's been elected to the New Hampshire State Legislature several times. Again, I don't have any of these credentials. I'm just an average person. She's also been a Christian missionary in Mexico and Central America. But like I said, overall, she's just an amazing person. And I'd love for you to meet her. And she's going to come up here and wow all of you and introduce the rest of her panel, which she single-handedly assembled. I take no credit. It turns out I know Eric from a previous walk of life, or not previous, but my current walk of life of many years prior. So welcome back. And Anyway, I hope everybody enjoyed the evening, and there is drink and food if you like. So I will let Erica come up and take over the introduction, or do you want to stay there and introduce? Would you rather do that?
For the introductions,
You'll
I'll come up.
stand.
I'll resume.
Assume the position. So I failed to mention, we always have to do this at CMEs. There's no conflict of interest. This presentation is brought to you by our CME committee. And as I said, Erica's going to come up and introduce the other panelists. So I'm not going to mention their names. She'll take care of that for me. So I did all this, and you can start with Rufa. Yeah, she did.
Well, thank you for being here. Thank you from the bottom of my heart, as well as I think I speak for everybody here when I say that we honor you for honoring us and coming into this room and taking in the information we have to share. There's a lot of valuable stuff. The world's changing. We've got a couple of quick comments just to orient you as to where we're coming from. Today's general American population is in a state of considerable cultural flux, and the greater national community regularly depends upon your capable care, and that community is in many ways emblematic of that changing landscape. So I wish to first express gratitude to management of this hospital and staff alike here at St. Joseph's for orchestrating this opportunity to enhance their fluency, their knowledge, and their grace in dealing as medical service providers with an increasingly diverse population. And further, I'm sincerely grateful for the honor of having been given the chance to assemble a sterling panel, professional panel, to help all of you to navigate these very, very human challenges and to optimize your medical outcomes here in your efforts to serve our neighbors, our families, and our friends.
Got some weird feedback going on. I don't know what it is, but
I'll shuttle back over to my previous
yeah.
spot, so perhaps it'll be good. Good, more helpful.
Oh yeah.
We've got a mobile microphone. Our panelists come from, Our panelists tonight come from many walks of life, as Dr. Manoli mentioned, myself, having no medical background whatsoever, and having relatively small amount of experience as a member of what I like to refer to cheekily as the Rainbow Posse, the Rainbow Crowd. But I'm flanked by people whose experience professionally and experientially far outpaces my own. To my left, to my immediate left, we have Rufa Sophia Okronos, and this is somebody that I'm tickled pink to be able to be introducing in this context, because we've been friends for quite some time and met at a trans-themed conference in Boston some years ago, became fast friends, both live locally, and I've learned a tremendous amount from her. I consider myself fortunate and blessed to not only call her a colleague, but a friend, a dear friend, and a mentor as well. Rufa hails from the Philippines, has lived here in the United States for 7 years, roughly 7 years.
Yes.
And during that time period has earned her legal citizenship here in the United States, has become an American citizen, and is doing a lot of very, very powerful things in both the performing arts community at large, as well as the community in general. A very visible person and a tremendous inspiration to me. A couple of the things that she has done is served as the best national marketing representative, marketing specialist, and a beauty consultant for Natasha Corporation in Leyte, Philippines?
Yeah.
Philippines. Mm-hmm. In 2020 was crowned Miss Infinity New Hampshire, and is also an active runway model for the New England region. Very powerful speaker. I've seen her present in a lot of public contexts, and really looking forward to what she has to say tonight. And further to my left, we've got Eric Senville, who I'm delighted to be able to say is my doctor. Erica's a PAC, correct. Works with the Elliott Medical Group in Hooksett, New Hampshire. Has a very distinguished background in this field, having done a lot of things, worked a long time ago as an EMT, I believe, and many other things. Adjunct faculty member with the PA program at the University of New England in Portland, Maine. The Pediatrics and Primary Care Department in Hooksett sees him every day. He's been there for about 3 years, I believe, and does tremendous work. I've talked to a lot of the staff members there, and they all adore him. Also, Doctor of Science Physician Assistant Studies, concentration in educational leadership, and I believe you were Phi Kappa Phi Honor Society, if I'm not mistaken. 4.0 GPA, folks. So, terrific doctor, and has a tremendous background in trans health specifically, and has gone to some of the best resources in the country, one of which happens to be here in Boston, in the Boston area, called Fenway Medical Group, where he has received additional training and specialization in trans health, for which we thank him profusely. And to my right, Sandra Lawrence Clark, also known as Sandy, PhD, is the Chief of Administrative Medicine and Occupational Health at the Manchester VAMC, at the Manchester VA. Also the Veteran Care Coordinator for the LGBTQ initiative, if I've said that correctly, alongside another good friend who's just dynamite. So that program at the VA in Manchester, which is like programs similar to it all over the country right now in all 50 states, is in extremely good hands. Earned clinical psychology, APA accredited at SUNY in Buffalo, New York.
You don't need to sit in here.
I don't sit here, I promise. A lot of trepidation where I was going with it, didn't you? And serves in the behavioral health department at the VA, and works with a lot of people who fit into this demographic about which we're assembled here to talk about tonight. A little bit about myself. As Dr. Malone mentioned, I've been in the performing arts for an awfully long time. I've been involved with filmmaking and performance, both in theater professionally as well as the movie business, television, what have you. Did a lot of that in a different guise, in a different modality. That was the person that came before. My view of that transition and my view of that progression is that life is a continuum. We all have transformations and transitions in life. This just happens to be the shape of mine. Just a human being who's on a path doing some evolving. It happens to be a bit more conspicuous, perhaps, visually. But it's not a whole lot different from some of the other watershed moments that people go through that bring them periods of hypergrowth or great change and great personal reckoning. So what I'm finding is that the further I go on this path, the more I realize that there's really very little difference, irrespective of what labels people choose to adopt and or impose and how they feel about those labels. There's really very little difference. We're all people, and we're here to, in this context, in this setting, we're here to care for others as best we can, as professionally and efficiently as we can. And the more we know about a person's personal needs as they present themselves, the better we can serve them. What I'm finding to be very salient as I continue to learn a lot about this subject is that there's a tremendous number of myths that exist out there that have just sort of grown up as a result of the general population not knowing much about the trans community or the LGBT community at large. And it's understandable that they wouldn't know. Those that fit under the rainbow umbrella comprise between roughly 10 to 12% of the general population. That's not a big percentage. So one can't be necessarily held to account for not knowing what one simply doesn't know. So there's forgiveness and grace to be had there. And what I'm learning as time unfolds is that it's incumbent on those of us who are conspicuously different to serve as best we can, some days better than others, as ambassadors or liaisons, and realize that the more good energy that we bring to a situation, whether we're stepping into a situation where we have needs or we're discovering somebody else who has needs or questions, the more open and the more candid we are and the more humor we bring to the situation, the better off everybody is. And I think those are, anecdotally speaking, I think those are a couple of things to bear in mind as you go forward and continue to try to generate the best health outcomes you can and put people at ease as best as you can, is keep it human, keep it real, and don't forget your sense of humor. Now, there's a lot of myths flying around out there that I wanted to dispel. I don't have time to do it, but I'm going to name a few of them. Myth number one, biological sex is a spectrum. Now, gender expression is a spectrum. There are those who assert that gender is a social construct. I've heard that a lot, almost to the point of cliche at this point. And I'm not going to really contend with that. You know, I've got my own views about that, but there's a big difference between biological sex, which is something you're born into, and your gender expression or your gender identity, and how you go about embodying that. And there's a lot of factors that impact the extent to which you feel at liberty to go ahead and do that. There's social pressures, there's family pressures, there's professional ones. And in every country, it's got and in every region of the world, it's got a slightly different complexion insofar as how comfortable people feel and how accommodated they are. So gender expression, yes, that's varied. We could call that prismatic, but biological sex is definitely, at least in my view, based on my scientific research. I've consulted with a lot of people, neuroscientists, sexologists, and what have you. One's biological sex is definitely not a spectrum. So that's a myth I just wanted to put there. There are those that may want to take me to task for that, but that's okay. And the idea that there are more than two, foundationally speaking, two genders is another one that's kind of up for continued debate, and we're going to let it remain topical and continue to be discussed, and that's fine. But the fact is that it's in fetal development that a lot of these things are determined. It's during fetal development that one's brain is subject to a certain hormone jacuzzi, if you will, and that has a lot to do with what the third interstitial nucleus of the anterior hypothalamus does and how it's impacted. So it's important to bear in mind that as these conversations publicly unfold, and as people come forward and ask for your care, who do feel that they identify differently than what's considered normative or typical, in a situation like that, it's not important to question it or take them to task or anything like that. Treat them like the dignified human being, deserving of honor and respect, just like you would anyone else, because that's really why we're here, to render care. There's a couple of things that I would bring up, but I'm just about out of time, and I really believe I need to get out of the way and make room for some somewhat more learned voices than my own. So without further ado, what I'd like to do is defer to Rufa, who will be taking the mic next and sharing part of her story. Thank you.
All right then, so, well, good afternoon, everyone. My name is Rufa Safiaranas, and then same age.
No, not necessary.
Anyway.
You're 27.
Yeah, thank you for that. Well, anyway, I was born and raised in the Philippines, so I grew up in a very conservative family, and of course, a country that have a strong faith in Catholic ideals. And one of the greatest things that I always bring with me is just like growing up with the influence of my parents, where actually my mother was a college university instructress, and my father was a police officer. So we have that stuff and background at home, like more likely in a military training. And growing up, I believe I was in elementary grade that I know that I'm a girl. So one of those things is like with my playmates, things that I love, girly things, that's what I used to have. And since my parents were quite busy, so I have a nanny with me. And of course, she was the one that always, was with my side. And one day, my parents was just like asking really what I want. And I told them that I am actually a woman. I am a girl. And I'm very, very blessed about that because my parents supported me. And I'm very, very proud of it because I have a very, very good, strong structure of my family. And considering that we have a good influence also in our community, I would say that I am blessed in that way because I never experienced being bullied. So growing up, like when I was in high school, in which I graduated in a Catholic school, St. Mary's Academy, and one of our curriculum is Christian living, that's moral values, in which it entails about, of course, religion. And the only thing that I learned about that, and I always believe, wherein when it comes to religious aspect for God, is love. And no matter who we are, what you are, it doesn't matter. So I had that good foundation growing up, and where I started transitioning at the part of my high school life, that it goes into like, of course, you need to grow your hair as a girl, but the hindrance in there, it's the school policy. But the good thing about it, because they never get into the part that they want me to be out in the school. So I graduated at that school, and of course, when I was in college, that was the time that I really like going into the process of real transitioning. And for the information of everyone, excuse me, if you are in Philippines, it's really different because here in the United States, there are people that care and we have doctors. Over there, if you're going through transition, it's always medication. You need to prescribe something for yourself. And the thing that we usually take in there, to feminization, it's the contraceptives. So that's what we do. So of course, if you're a student, the one that will provide for you on that, it's actually your family. It's going to be coming out from your pocket, in which I'm very grateful about that because my family, as I have said, they're very supportive about me on that. So the only thing that I would say, I don't want to make this too long. I am very grateful that I was able to come to the United States, and being here, it gives me a different perspective because when I was in Philippines, it was all about how I complain, those people that they need help in, and also like how they will grow as trans. And on the other side of it, there are some organizations that they help transgender, but of course, the transitioning itself, when it comes to finances and to an organization, they don't really cater that. It's hard. And coming here to the United States, merging my culture from Asia to the United States, it's a big thing and a big education for me because when I got here, I've met people in the medical field, including Eric, which is he is my formal therapist. So I'm very grateful being here. And when Erica told me about this, this event today, I was having second thought because I live my life the way where I believe in myself that my gender or who am I, it doesn't matter. So I'm a get-goer person. So I don't friend, being a transgender. I don't really say that out loud. So everywhere I go, I present myself. I am a person. I am a human. I am competitive. And whatever I want, I'm gonna go and get it. It doesn't matter to me if I am, what people would say. So that's one thing that I've been always, of course, telling my friend that it doesn't matter what's in between or what people would tell. But the most important thing for us is to know who we are inside. I mean, being us, there's nothing wrong because for me, it's just all about being a person and being a human. And if you want a respect, of course, you need to start it within yourself. If you want a spot, if you want to be recognized, you want a credibility, you need to work hard for that. So I myself, I always put that in that way because for me, like being a transgender woman, as I have said, I don't really put that in front of me. I always go and move forward for a future wherein I consider myself, I am a person and I'm capable of what I can do. Thank you.
Great. Thank you so much. Sorry.
Reach across here.
We're gonna send them over.
We're gonna do that real quick. Yep. Give you the sign.
Thanks very much, Rupa. Appreciate what you have to say. Next up, Dr. Lawrence Klum.
Hi, thank you. So this is a topic that's near and dear to my heart. First of all, it's extremely important to the VA to reach out to our LGBT veterans. Americans who are part of the LGBT community have much higher rates of military service than people who are not part of the community. The VA recognizes that, and so we want to make sure that we can provide them with affirming and competent care. So we work very hard at that. The other thing I want to say is that anytime we're talking about members of the LGBT community, we're talking about minorities. And so when I do presentations, I always use the terms sexual and gender minorities because their minority status is what creates the healthcare disparities that they experience. And so it's very important when you're providing care to keep that in the forefront of your thinking. They have all of the same healthcare disparities as other minorities do in this country. And so I just wanted to put that out there. The other reason that this topic is near and dear to my heart is because I'm part of the community also. So I identify as a lesbian. And about 6.5 years ago, my then wife came out as transgender and has since transitioned to male. And so I've seen sort of the whole aspect, the whole gamut of experiences. And I know personally how much more difficult it is for us to access healthcare. And I could tell you, a couple hours worth of stories. Just some horrible experiences that we've had. And I don't want other people to have to experience that. Even just this week, my spouse went to a podiatry appointment and was all stressed out because anytime you get referred, your whole medical history goes with you. And so there's, the various surgeries that he's had and the hormones that he takes. And all he wants is his foot to feel better. And so then he worries about how the podiatrist is going to welcome him or not welcome him. Are they going to misgender him? That happens more than it's much more than it should. I know that this presentation has to do with the mammography department, and so my spouse has to get mammograms every year because of a precancerous condition that was diagnosed from a pathology report after his top surgery. So we have to navigate mammograms every year with him presenting as male. And it's just horrible. And so the way we do it is we go together and get them the same time. And we get the last 2 appointments of the day. Because otherwise you have women walking in and they see a man in the changing room. The technician, almost screams because men aren't supposed to be in the changing room, and yet that's where he was told to go because that's where his appointment is. And so most people would then just avoid healthcare, which is what many in the LGBT community do. They just avoid going. if they can afford to go, because of course the rates of unemployment and homelessness and poverty are extremely high in the community. But even if they can access care, they don't, because it's very, very difficult to do it successfully and to do it in a way that feels comfortable. And so that's really what I wanted to emphasize by coming tonight.
Thanks so much. Thank you. Our fourth panelist.
He comes with slides.
Comes with slides. Came prepared.
He's going to, wow.
Just gonna give it a few seconds and it should switch over, but in the meantime, I can.
And I'm personally opined that Erica Sandville is one of the best healthcare practitioners in the state of New Hampshire. But that's just me.
Hello, everyone, and thank you for having me. So while my slides are still getting ready to go up on the screen, I'll just give you a little bit about my background. So as we said, my name is Erica Victoria, and I'm a physician assistant that works in pediatrics and adult internal medicine in Hooksett, New Hampshire. As part of that primary care realm, I also started my own specialty LGBT clinic within primary care because that's where I believe LGBT health belongs, is very much in the beginning in primary care. So as part of that journey, I've kind of become more and more educated on LGBT health. I do a lot of training at Benway Health in Boston, which is kind of one of the premier places, especially on the East Coast, for LGBT health. So I do a lot of training there. And last year, I also received my doctorate in physician assistant studies, where my thesis was pretty much all on how do you educate healthcare providers about LGBT health? What's important? What do you need to tell people about? So with that being said, I'm just going to still wait for this thing to heat up here. Maybe I have to press that button. Give me 1 second. Let's see if that does it. Maybe. Well, we will wait for it anyways. But so just a few disclosures about myself. So I identify as a gay man. I am cisgender, meaning that I do not believe that I am transgender. I believe that I identify with the same gender identity that I was assigned at birth. And so pretty much I take a different lens than some other people do about LGBT health. So I just want you to know that as I'm talking about these things. So pretty much the first thing I want to talk about, we alluded a little bit about, why is it important to notice that people are considered gender or sexual minorities? And that's because there are so many things that happen in an LGBT person's life that makes it so that they are disadvantaged in some way. Whether that is because they have lower education status, because they were kicked out of their homes, or because they weren't able to go to the best schools. Perhaps maybe they had higher stress levels because they came from a household where it wasn't okay to be an LGBT plus person. And all of these things throughout a lifetime can actually cause a lot of stress in people. Increases cortisol levels, creates worse outcomes for the heart, causes diabetes, causes people to need to use substances like drugs, alcohol, tobacco in order to cope. So that's really important to think about why we are a minority people, just as Sandy alluded to before. So what does this stigma actually do? So like I said over here, all these little stigmas and all of these things that we see as negative on social media, the news, we hear from our parents when they're at dinner, those are all things that people really take to heart that are LGBT. What someone might think is just a little comment or a little joke, we can listen to that and be like, oh my God, I don't think my parents love me now. And that is something that we hold with us, and that can be really harmful to us with healthcare outcomes as well. So what do these healthcare disparities look like? So I put a few of the things up here. There are so many healthcare disparities, but just to highlight a few. 82% of LGBT children face harassment in educational settings. 50% of transgender people have been sexually assaulted. Gay men are 44 times more likely to contract HIV compared to heterosexual people. LGBT people have higher rates of eating disorders, sexually transmitted diseases, smoking, alcohol use, and drug use. Physical and emotional trauma cause depression and anxiety, leading to high suicide rates in LGBT people. 65% of LGBT physicians have actually heard one of their colleagues mocking LGBT patients. 19% of transgender patients have been actually refused care by their primary care provider, not because that they overtly were discriminatory, but because they didn't know how to help them. And 70% of trans patients report discrimination at one point or another at a healthcare facility. So it is something that is very common. So specifically looking at trans people, I think it's really important to look at that group because when you're looking at LGBT health, that is the one that is the most medically marginalized. So you see higher rates of depression, higher rates of suicide attempt. In fact, in the trans population, 41% of trans people have attempted suicide. I'm going to say that one more time for emphasis. 41% of trans people have attempted suicide at some point in their life. That's huge when you think about what the general population is. It's less than 1.6% of people, the general population. So it's a huge statistically significant difference. You also see higher rates of smoking, higher rates of drug and alcohol use in about a quarter of these patients. You see higher rates of HIV, and also people engaging in sex work in metropolitan areas in order to survive. So whether that is exchanging sex for shelter or for food or for money in order to survive, especially when people aren't able to keep jobs because employers are discriminating against them. So why do we need to learn about this? Yes, they're LGBT people, yes, we accept them, but why? Why do we actually have to do something different than just being nice and kind to people? Well, truthfully, a lot of people don't learn about this in medical school, nurse practitioner school, PA school, nursing school, any of these things. And within the past 10 years, you've seen a great increase of accrediting bodies requiring this to be done. However, you have a huge gap. You have a bunch of people who have already graduated medical school or nursing school and still haven't gained that knowledge. And so part of my mission is I try and fill in those gaps with my own healthcare system and other healthcare systems in the Southern New Hampshire area. So you see, over here I have a few different kind of articles that were written about emergency residents. So this was actually in 2019. They found that 63% of emergency residents today, so people that have just graduated from medical school, actually feel like they're not able to ask sexually transmitted disease questions when it's clinically relevant to LGBT people because they don't know how to approach the topic. In fact, 28% felt uncomfortable doing exams on transgender people. They weren't sure what they could do, they weren't sure what would be appropriate, or they weren't sure what they were looking at. And 6% of those doctors actually felt that LGBT people deserved less than the standard of care. We're not talking about a statistic that was done a long time ago. That means 6% of emergency residents today feel that way. So it's really important that we educate people on this more. We also see that in psychiatry residents, there's a vast majority that feel that even though they learned about LGBT health in their training and residency, they don't feel that they learned enough to be clinically relevant. You see the same thing in medical schools as well. Even though they offer 5 hours of curriculum, people don't feel like they learned enough to actually practice medicine in that. And the same thing with nursing programs, so across the board. So, why am I bringing you down and telling you all these statistics? Well, because I want to bring you up and tell you what happens when we give good affirming care. I'm not talking about giving people surgery or hormones or anything like that. I'm just saying affirming people's gender in the clinic areas, whether that's the secretary who answers the phone and uses the right pronoun, or the person who writes the letter and uses the correct name, or the medical assistant calling the patient back and using the right names and pronouns. These are all really important and affirming to patients. And that's why we need to make sure that everyone, no matter what their role is in a hospital setting, is trained on these types of things. So you see that when we start giving affirming care to patients, 74% of trans patients felt that their mental health got better. Suicide rates dropped from 19 to 29% in one study, down to 0.8%. That's life-saving. Using someone's correct name and pronoun saves lives. I tell people all the time that I've saved more lives with a rainbow sticker than I have with my CPR training. So granted, I work in primary care, so that's probably a good thing. But nonetheless, I think it's still important and relevant to let people know that signs are visual reminders of kind of what we need to show people that we are caring and accepting. You also see that trans patients, when we give affirming care, have seen increased life quality. They feel overall improvement in well-being. When you're talking about surgical procedures, so for people that offer surgical procedures, there's always the concern of, well, what if my patient regrets the types of things that I'm doing? And I tell people the regret rate is actually extremely low, especially when you're talking about hormone therapy in the use of children or even adults. It's a 99% chance that that person is going to be satisfied with the results or happy that they did that. That doesn't mean that 1% regret what they did. It means that 1% may not have gotten all of the features that they wanted to from those types of hormones. Actually, we know that regret rates are less than 0.1% of trans people who have started some sort of hormone affirming or surgical affirming kind of procedure. With that being said, I also have the satisfaction rates for different surgeries across multiple different healthcare areas as well. So we know that these things save lives, and we know that teaching parents about this saves lives as well. There was a great study that actually looked at parents and children when one child was cisgender or not transgender, and when one was transgender. And we found that the parents that were loving and accepting, shockingly, their children had better mental health care outcomes. It decreased suicide rates drastically. It made housing problems 0%. None of those children were homeless or felt like they needed to leave home, which is really important for education and health outcomes and just overall risk factors for that child. And you see here, 57% suicide rate with parents that are not accepting, and 4% with children who have parents that are accepting. So it's a huge statistically significant difference as well. So that's kind of my little spiel on why is this medicine so important. I'm going to take just a few more minutes just to talk about some basic terminology, how we talk to people about pronouns, what to do when people come out. And then after that, we'll open it up for questions. I'm sure that there's a lot of people that have questions about this. So basic terminology, I love the gender unicorn. There is another kind of little picture that you can use too, but this is the one that doesn't have a copyright. So I use the gender unicorn for everything. And it's great because it shows the different spectrums of a whole person, right? Gender identity and sexual orientation don't have anything to do with each other. Sometimes gender identity and gender expression aren't even the same. So I want to go over what all this means. So gender identity, as Erica said, is what you feel you are on the inside, what you feel your gender is. And there are spectrums to that. You know, there's the masculine and feminine, and people can sometimes be somewhere within that. Sometimes people are in a persistent area their whole life. So, I'll wait 1 moment.
May I have your attention, please? Stroke team, activate to the ER. Stroke team, activate to the ER. Stroke team, activate to the ER.
Okay, we're back. So gender identity, like I said, is usually in a persistent area your whole life. Sometimes that can change for people, and sometimes that changes even on a daily basis. That's when we kind of use the term gender fluid. When there's this fluidity of people feeling more masculine one day and more feminine the other day. The other thing is agender, or people that feel like they don't fit on that binary at all. So there's a lot of different language that I'm using. I'm going to show another slide where it kind of breaks it down a little bit more. Gender expression is how you appear to other people. So for instance, a person that might be earlier on their gender journey might feel on the inside that they are male per se, and they might still express that they are female. So sometimes gender expression does not always match what a person feels on the inside. I'll give a kind of a little anecdote. When I was first starting to work in trans health and I was shadowing an endocrinologist, he told me that we were going to be going into this room of a trans female patient, and that we're going to talk about hormones. So I go into the room, and I had my own kind of ideas of what that patient should look like, right? I was like, okay, well, this person probably, wears feminine clothing, maybe paints their nails, wears makeup. And I go into the room, and it is a person who presents with baggy jeans, dirty t-shirt, a beard, long hair, And I said, okay, did I go into the right room, first of all? And then it was like, okay, is he playing a prank on me? So there was a lot of things that went into my mind. But, you know, as I was able to kind of get a hold of it, I was able to understand where this patient was coming from more and why she presented the way that she did. So I had, you know, a few moments where I could ask her, you know, I noticed that you have a lot of facial hair. You know, with, you know, feeling trans feminine, why is it that you still have facial hair? And she said, because it's so traumatic for me to look in the mirror every day and think about shaving it. And that was really impactful for me. And then I kind of understood, it's like, wow, okay, people's gender does not always equal gender expression for various reasons. So as Erica also mentioned, sex assigned at birth is not as much on the spectrum. You can argue it kind of can be, and I'll explain that. But what that means is that when a child is born, a doctor assigns whether or not they are male or female. The problem with this is that about 2% of the population is intersex, or ambiguous genitalia, or has some sort of condition where they may not be totally male or totally female on a biological standpoint. Unfortunately, in the state of New Hampshire, on birth certificates, we have to put either male or female. So that is one kind of issue. And people that are intersex can obviously have different gender identities as well. It's a whole rabbit hole that I'm not going to go down today. But I just wanted to kind of let people know that there are technically 3 sexes. 2 of them are used in New Hampshire. And then also physical and emotional attraction. So that's when we start talking about sexual orientation. Who are we sexually attracted to? Who are we romantically attracted to? So when you're talking about sexual orientation, there are multiple different aspects of it. So one is, who are we attracted to? You know, who do we want to, you know, engage in sexual intercourse with? The other thing is, who do we actually have sexual activity with? So for instance, you could have a teenager who may say, okay, well, I'm sexually attracted to men, but they may have never actually had sex with men before. Well, that really changes their healthcare outcomes, the things you'd be screening for and asking for. It's definitely important to know because you're looking more at the mental health aspect, but that's another part that's just part of the sexual orientation. And then sexual behaviors is all part of this as well. Romantic attractions, who do we fall in love with? Who do we marry? Just because you are married to one person of a specific gender does not mean you can't be bisexual or pansexual or anything like that. So to talk a little bit about gender language, I know we've thrown around a few terms, so I just want to clarify what all those mean. So the first is transgender. So that means a person who feels as though their gender identity does not match the sex they were assigned at birth. Another term is cisgender, meaning that what they were assigned at birth is how they feel they are on the inside. So meaning not transgender. The majority of people feel as though they are cisgender. You have trans male, so this is a person who on their gender journey was assigned female at birth, but identifies as male, and the opposite for trans female. Like I said, gender fluid is when people move along that gender spectrum, but kind of like maybe every day they might switch, or every few days, or every few weeks, or maybe every few months or years. You can kind of have that fluidity. Gender non-binary is a person who does not feel that they belong in that kind of spectrum of male or femaleness, and agender feels as though there's something other than any of the other genders that have been described so far. And then gender grammar. So I want to go over real quick too, because I mean, I'm a healthcare provider. I read a lot of notes, so I know what people are typing in notes, even though their patient might not know. But their patient can access a lot of those records now. They are able to see things, and if you make a grammar mistake, it makes a big difference in a person's life. So for instance, we don't use any words that have ED at the end anymore. So we don't say a person is transgendered, we say a person is transgender. We don't say things like a person's intersexed, we say that a person is intersex. So we don't kind of just qualify them with those ED kind of words. I always tell people when we're writing in notes, or we're writing in documentation, we should always be using person first anyways, right? We shouldn't be saying, oh, my diabetic patient. We should be saying, my patient with diabetes, because the diabetes is not the only defining factor about that person, just like their sexual orientation or their gender identity. So the other things that to think about is you shouldn't use transgenders or anything like that. It is a transgender person or a person who is transgender. We also don't use the term sex change or sex reassignment surgery. Those are all very old terms. Now the terms that we are using more often are gender affirmation surgery. So we are affirming the gender that a person always felt that they were. So that, I think, is a more powerful language to use, and it's the language that I use with my patients. Pronouns. This is when we go back to English class real quick. So pronouns always gets to be the hot topic here. It's real easy. She, her pronouns, he, him pronouns, same exact things that you have learned all throughout your life, okay? I will get into talking about how do we broach the topic of pronouns with patients. They, them, theirs pronouns. So I love when people tell me that they can't grasp this concept, because it's actually much easier than you think. And I tell people, think about, an instance where maybe you didn't know who a person was, but you were describing it. So I tell people, what if someone left their sunglasses in our clinic? We would try to figure out who they are. We would call their phone, and then we would also give them back what is theirs. So just because you don't know their gender, you don't know who they are, it's still singular. And for the grammar fanatics out there, Merriam-Webster's dictionary says it's okay now to use that. And you use the same exact verb tenses that you would use for they, them, theirs any other time. You don't have to do like they, is. I see people doing some funky grammar stuff. You don't have to do that. Just say as you naturally would with the actual verb. I also put the Z pronouns on here just to tell you there are over 16 acceptable pronoun sets for people. With my patients, most of them will use one of the sets of pronouns that are in the top 3 here, so the they, them, their, he pronouns, or she pronouns. But there are many others. And I put the Z pronouns in here to let people know that sometimes someone will tell you they have a pronoun that you have never heard of before. And that's totally okay. You can ask people, okay, can you tell me more about that pronoun? Or you can just say, I've never used that before. Are you comfortable with using a different pronoun? Or would you be offended if I just use your name instead of using pronouns? So sometimes, especially when I have a new patient and I don't know what their pronouns are yet, I will usually use the name that they give us as their preferred name. Or I'll say, oh, my patient in room 4 needs this and that. Those are the types of ways that we can get around to using pronouns, especially when we don't know yet. I don't like to use pronouns for people that I haven't met yet, because a lot of my patients, I find out, they might use a different set of pronouns, even though they weren't even a patient that was listed as one of my specialized LGBT patients. So I always kind of wait to talk to patients about that. So everyone always asks, well, how do I figure out if someone has different pronouns? Okay, so let me tell you, it's much easier than you think, and it's much simpler than you think, and it's not scary, okay? So when I have a new patient, I go in the room, and the first thing I always do is I ask, I confirm the name that I have on the chart. I say, do you go by that, or do you go by any other names? I think we should do that with every patient, not just patients that we think are transgender, but I can't tell you how many patients I have named William that go by Bill, or go by their middle name. And you feel silly because you're calling them a name that they've never really been called before. And it makes that environment sterile, and it makes it feel like you don't really know them. So I think it creates a better medical kind of home for the person to come in and to use the name they feel comfortable with, whether they are transgender or not. So that's my plug for that. So one is if you notice that a person's name maybe doesn't match the name in their chart, and it seems as though that they could be, a different gender mismatch from there. Totally fine to say, okay, well, what name do you go by? Do you have any pronouns that you use? That's totally fine to do. And sometimes you'll get people that'll look at you and be like, pronouns? What? That's fine. Just breeze over it. You're like, don't worry. That's not the person that we need to worry about to use different pronouns. We don't have to do a whole education session on a person's pronouns. The other time that I will typically ask people is I will normalize asking pronouns as I do with any other social history. So for instance, when I'm going through my social history, I'm asking you about your parents. I'm asking you about, have you ever used tobacco products? Have you ever been sexually active? And they say, do you have any pronouns that you use? Easy enough. I put that right in there. So you can normalize these types of questions. So when in doubt about a patient's pronouns and you're scared to ask, it's okay to just avoid the use of a pronoun by using a person's preferred name or by using names like the patient or something like that. So I recommend, every new patient that you have, asking them if they have a preferred name to use. And like I said, we never assume people's gender identity based off of their appearance because you never know what they feel on the inside. That doesn't always equal their gender expression. So the other thing is, I know there's this whole formality in medicine where we use, sir, ma'am, that type of thing. I don't use that language at all. I never have, even before I did LGBT medicine. One, I feel like in all of the social media videos and the TikTok videos, if you want to make someone mad, you say, sir, please calm down, or ma'am, calm down. So I don't do that. But what I do instead is, you just ask people, how may I help you? That type of thing. You don't have to add sir or ma'am into anything. So like I said, you can say the patient's in the waiting room. I never ask people what their mother and father's names were because there are so many different family dynamics that people have. Some people have 2 fathers, 2 mothers. Some people have 2 sets of parents because of different family dynamics. So I tell people, I ask questions about their parents, their guardians, who do they live with? I don't say mother or father or put that on forms either. When you have a form that says mother or father, or it only gives you the option of male or female, people will immediately say, I don't feel like I fit into this form. How will I fit into this clinic? How will I fit into this healthcare facility? So it's a really important thing to make sure that we have blank spaces for people to write their own gender identities, the names of their parents, that type of thing. Instead of saying mother and father, you could do parent 1, parent 2, parent 3, parent 4. So those are all really important things to consider in our clinics. So just different things about gender affirmation or transition. Transition is still an approved term that we use. It's not considered derogatory, but we feel as though gender affirmation just kind of is more inclusive of what we're doing. So the first thing you see in most people is this social transition or affirmation where people take on different names. They will start to usually dress in a way that they feel more comfortable and aligns with their gender identity. And typically they'll do things like change gender markers or legal name, all things that can be changed back. There's nothing permanent that's been done at that point. Some people will also opt to do hormones to help affirm with certain body features or even with mental health. We know that hormones do help that. And other people will also look to surgical means for different types of affirmation. This is the general journey that people take, but this is not the journey that everyone takes. In fact, I have many patients that really want to have top surgery or remove chest tissue before they start any hormones. So you see that sometimes these go into different orders. People don't want to start growing a beard when they still have a lot of chest tissue. So these are things that you need to think about sometimes when working with patients. Not everyone's journey is the same. I have some sexual orientation terms here as well. I think most people are familiar with gay, lesbian, bisexual, but also I get asked all the time, what does it mean if someone is asexual? So asexual does not mean that a person does not have sex or has never had sex. It means that that is not the forefront of their relationships. It's not something that's driving it. Asexual people typically like to have more emotional attraction. They certainly can have sex, they can have children, but it's just not something that they feel is necessary in their relationships with other people. Queer is another term that I know a lot of people sometimes feel uncomfortable using. I will tell you that there are 2 types of queer, okay? There is gender queer, which is when a person's gender identity, they feel like it doesn't fit in any of the boxes. And there's also a sexual orientation term called queer. These are both self-describing words, so they're words that people use to empower themselves and use that to describe their experience. As a healthcare provider or another person, I don't tell someone, okay, well, you are queer. It's a self-describing term, so we don't use it in a derogatory sense like that. We can mirror any of the language that a patient uses, and we can say they identify as queer. That's totally fine, but we don't put that label on someone. And then the big one that everyone always asks about is what is pansexual? This has nothing to do with pots and pans. This has everything to do with a person who is sexually attracted to people without regard to gender identity. So this includes attraction to people who are transgender or cisgender. It is this full spectrum that they are sexually attracted to. So this is my last, sorry, two more. How do you respond when someone comes out to you? One, you always thank them for sharing that information because it takes so much to come out to someone. I can tell you, so I am a physician assistant and I have been out since I was 18 years old. And the last person I came out to is my healthcare provider. Even though I was a licensed PA working in LGBT health, I knew that my healthcare would change in a positive way if I did, but that's how hard it is. It's not easy to tell someone something about you. When you're talking about minority stress models, some people feel shame or guilt about their sexual orientation. And that's why it's so important that we give opportunity to people to talk about their sexual orientation in ways that are very affirming and non-judgmental. For instance, when I'm talking to my patients and I'm asking them if they're sexually active, I think most people in medical school were trained, okay, do you have sex with men, women, or both? That's really concerning that we use that type of language for a few reasons. One, it doesn't encompass transgender people, and two, people worry about judgment. So what I do is I ask, are you sexually active? And they say yes. And I say, okay, do you have sex with men, women, something else? And then people will open up about that because they think, oh, okay, he said something else. Maybe he is, kind of on the up and up about this language. Also, I have rainbow stuff on, so people usually feel like it's a safe place. I'm not shy about my own personality or, my own lifestyle. So I think I'm pretty affirming when it comes to that. But then you pretty much follow up with questions too, right? You don't want someone to say, oh, I have sex with men and I'm a man, and then just switch to something else. That leaves like a cold, okay, are they okay with it? Are they not? Did I make it awkward? Instead, I ask people, oh, that's great. Do you have a partner that you're with currently? How long have you been out for? Is that something you share with other people? Just so I can kind of gauge and build that connection. You can't do that with every emergency room visit or every time that you're running in to help someone. But when we're in a room by ourselves, that's good to really kind of build that connection with the patient. So like I said, never respond with silence. So how do we create welcoming environments in healthcare? Well, we show visual representations of support, like our little rainbow stickers and pins. We ask every patient what their preferred name is, update charts to accurately reflect names and pronouns. We never assume a person's gender identity based off of their appearance. We never assume sexual orientation or diseases based off of someone's sexual orientation. We should change all healthcare forms to be inclusive of LGBT people. We should ask patients as well how they refer to their own anatomy. Especially in trans people, we worry about the sense of dysphoria or losing the sense of self by using the wrong term to describe. So I like to use terms that maybe are less descriptive. Like before when I was talking about trans men, I used the term chest tissue and I didn't use breast tissue because that can be very dysphoric where people could feel really traumatized to hear a doctor say you have breasts. Instead, I say, okay, well, I'm gonna just do a chest exam or we're gonna do a screening to look at chest tissue. That's a really different change in language that's very descriptive. I mean, patients know what that means, but I'm not using a kind of a word that they may feel is not something that they have. Same thing when it comes to genitalia. I say, okay, well, we need to do an internal genital exam or an external genital exam. If they're okay with me using, the true anatomical terms, I absolutely do. But if they have other names for it, I'll mirror that language as well. I also ask patients what gender chaperone they would like inside the room. Because obviously people have different gender identities. They may have experienced certain traumas in their lives where they will prefer one gender or another. I tell people I always have another person in the room when I'm doing internal exams. So I always want to make sure it's the most comfortable setting for a patient. So with that, I have spoken way too much. So now I will give the microphone back to Erica and we can move forward.
Thank you very much. We're going to shortly be opening up for questions. There's a handful of us here. I imagine there are some, and I don't know to what extent we're monitoring those who are with us virtually online. But Maureen, are we able to take questions from folks?
I do have one right now.
In a chat room, that kind of thing. Before we get to that, there's just something that I wanted to say that I was kind of inspired to say as a result lot of the things that have been shared throughout the evening, which is that we're talking about having an affirming environment, a welcoming environment. Well, I'm here to testify that, you know, as baby, transgender woman of only 3 years, I live here in Nashua. I have done for a long time, raised my kids here. I give this city top marks, in my view. Top marks, socially, culturally. I mean, you know, I've heard a lot of rough stories and testimonies about what people have experienced throughout history and all over the world. And this city, my home city, the city that I represented once upon a time, or former self-representative in the state legislature, and did so proudly, has exceeded my expectations. Just boggled me, because nearly never have I encountered some kind of overt exhibition of disapproval out and about in public, going about one's business, buying bread, you know, here and there, or even in medical environments. So people can do this. They do it every day. We can do it here. And look, statistically, look at the difference in the outcomes, the impact it makes on a person's life. It takes a little to do a lot. And I've seen it work time and time again. And not one day goes by that when I hear a man, I happen to like him. Or just, you know, it's obvious that you know, somebody's on board. Whether they've read me or not, it improves my entire day. There's a tremendous uptick in my general mood and outlook and self-image. So I'm telling you, this is a lot easier than you may think. And that's why I put that in the title of tonight's talk. Do no harm is part of the Hippocratic oath. So, let's do some questions. Sure.
Me?
Yeah.
Oh, is there a way that you can give us a copy of your slides so I can hand them to my coworkers?
Yes, I do give copies of my slides. And also I do other presentations as well. So I like to also go to even like meetings of, you know, like sometimes you have like meetings in your department. I love to be able to have the opportunity to teach people about that as well, so we can have live discussion about it too. Some of my presentations, I go a lot further deeper in the medicine of it, and how do we do screenings, what screenings need to be done, what types of immunizations need to be done, what are hormones, how do you dose them, what are the different surgeries. So I go much deeper in that, but yes, I certainly can. Yep.
The reason why I ask is we have had a couple of patients in that area.
Yeah, and I think that when I was starting to kind of talk about this and do this medicine in my own hospital, we were upgrading to Epic at that point in time, and part of the upgrade to Epic was that you were able to start to write down what people's pronouns were, their gender identity, and there was this huge scare of what if people do this wrong? What if people start offending people by asking these questions? And so that's when I kind of took over, and we revamped so many things in our hospital. We no longer put gender markers on hospital wristbands. The name that you prefer in the chart is the largest name that you see, and the legal name is tiny little letters underneath it. And that has made a tremendous impact. Something that I was just like, well, why do we need a gender marker? Is it actually clinically relevant? And we asked every single department, and they're like, no, we don't use it. It's like, so why do we put it on a hospital wristband? So we took it off. And there has not been a single issue because of it, which is pretty amazing. And in fact, I would say most patients don't even realize that it's not there. But I have seen some trans patients taking pictures of it, posting to social media and being like, look, there's no gender on this wristband. That changes a person's day. It changes their experience in that healthcare setting. And it also reduces the risk of them being misgendered or being told the wrong gender using the wrong pronoun. So, yes, happy to share things.
Thank you.
No problem.
Sure.
So, to Dr. Lawrence Clark, I think. A lot of what we talked about has been, so I'm Dr. Outgood and I'm a psychologist. a lot of what we talked about has been the social aspects of, your everyday experience, and I appreciate that. But there are also some structural issues that come into play that I face every day. I'm a testing psychologist. As you know, many of the tests are gender normed. I had one client in particular, and I've been doing decades, but I had one client come in who did not want to declare a gender. Well, I do some of the psychological testing online, and I use Pearson psychological testing products. I talked to Pearson about this, by the way. And there's a red asterisk next to the gender. You know what that means, right?
Required.
It means the software is not going to let you go on unless you declare something. It's just not going to work. So I talked to this gentleman about that, and he did not like that at all. Simply didn't like it. And I said, I'm sorry. And I explained what a validation process is. And I explained that these were not my tests, they belong to Pearson, that I have no control over the software. And he didn't have to take the test, but I don't want to say he had a chip on his shoulder. He was not happy about that. So he left. And the next thing I know, he's posted online all about this and that it's all my fault, as though I own Pearson. I would love to own Pearson. But I have to believe that medical doctors face some of the same issues. There are gender-specific things, medications that you have to give to one gender, maybe not another, that come up. Some things that are simply beyond our control. Of course, the one I'm concerned with is the psychological testing. Do you do psychological testing?
I do.
How do you deal with that?
So, and I can give you, if you give me your email, I'll share with you an article that talks about how to use norms in psych testing on transgender individuals. Essentially, it's a judgment call, and so you have to take into account, for example, how they were educated. So you might ask, what gender were you considered when you were in school? Might be a more sensitive way of asking.
The software doesn't have any say. It just,
Right, but you have to think about why gender is important.
Yeah.
And often it's because of educational differences, in the past. Or you might take into account if you do know that they have transitioned, how long have they been socialized and transitioned in that gender? If they just transitioned yesterday, you may want to, consider the gender that they were formerly considered as. If they transitioned at the age of 14 or, even 10 years ago, you may want to consider using the gender that they now identify as. If someone refuses to answer, then I think you handled it pretty well. But again, maybe just getting around it by were you educated as a different gender than you're now presenting as? Might be a little bit more sensitive.
When I called Pearson, the gentleman I spoke to said, we know, we get these calls. I wasn't the first one that called. But all I can tell you is we're working on it. And I said, great, so like next year?
Yeah.
No.
If they add the X, that might solve the problem, right?
Well, right.
Or allow an option of not unnormed.
But then statistically, they would have to validate for an unknown population, right? It isn't that easy. They have a lot of research to do. And I get that. So this isn't going to be fixed tomorrow. But I got to believe in the medical community, they have very similar issues.
But there are similar issues in the medical community with ethnicity, right? I mean, how often, if someone is a multiracial background, how often do you go into the weeds of what ethnicities they're comprised of? And our norms don't even consider that. So if this person in front of you maybe isn't as Caucasian as I am, and you suspect they might be a person of color, how do you address that? It's with, sensitivity and respect. I think if is the best way we can do it, and apologizing like we did, that it's not a fair system, it's not a perfect system.
So I'm going to speak to that real quick too.
If somebody wants to use the podium, like that's the bell, just so you don't have to.
So you did bring up a great point that there are a lot of medical tests that the values of norm are either male or female. And you bring up a great point as well that they are validated for male or female. We don't have a lot of studies on trans people or people of gender minorities to know what's validated. Even more so, okay, well, what should someone's hormone level be when they've been on testosterone for 1 year? There's no validated tool for that. There absolutely is not. This is where the art of medicine comes in, because you have to take into account, okay, are they on hormones? How will that change their body physiologically? Over what period of time will it change? So for instance, I'll talk about red blood cells. So in a person who is assigned female at birth, there will be less red blood cells in the body on a regular test. However, even though that was their sex assigned at birth, if they start using testosterone right away, they might not have any big changes in red blood cells. But over time, they're going to be way higher than they would be on a person who is assigned female at birth, because that's what the drug does. So then you have to change your values and adjust for male values. So here's what I do in practice, quite honestly, is I look at both male and female values of norm. And I use that information to help interpret lab values. The same issue comes into play when you're talking about vascular disease risk. So when we use the ASCVD calculators to see if someone needs to be on a statin, it only comes in male or female. You can't put anything else. So you have to think about, okay, well, what was the predominant hormone for most of their life? And how long have they been on testosterone or estrogen for? So for instance, if someone's been on testosterone for 10 years, I'm gonna put male down. If someone's been on testosterone for 6 months, I'm probably gonna put female down just because of the predominant hormones and the changes in the body. So, psychological testing, definitely, I know exactly what you're talking about because I work with children and I do Connors forms, which are male and female, and they are vastly different sometimes. And I have trans patients that have ADHD, and I have to do both the analysis of male and female to get a good picture of what I'm doing. I don't know if that's the right answer for everyone, but for a lot of my patients, I do that just to kind of compare, is there a big difference between male and female?
But the risk there is a type 1 or a type 2 error, remember that?
Oh, yeah. Yeah. No, I know. So, but the answer is there's no great answer for it. And that's the problem. And, when it comes to, I tell my patients all the time, there's a lot still to be learned about trans health. Because when you're talking about a marginalized group in medicine, it's really hard to do good studies on them. The reason for that is because they're already vulnerable. So the more studies that we do, the more people are worried that we're just using a population. You see that a lot, especially with race and ethnicity, when people were kind of doing medical experiments on people for the same reasons. There's a lot of stigma about that. So yeah, I know it's not the easiest thing to figure out. I'm hoping that with time, with years, we will figure it out, but there's definitely no simple answer now. Yeah.
I've been a physician for many decades. And you have no idea, well, maybe one or two of you have a little idea of how unusual this meeting is. I have been with my now wife for 36 years. And in the beginning, that was a very sheltered piece of information. So I was married for 10 years, had 2 kids, and then have been with my spouse ever since. I remember going to a tumor board here 30-some years ago, and a patient had Kaposi sarcoma now. So, and I said, well, did you do an HIV test? And it had not been done. And the physician, who was much older than me, said, I don't know how to ask. I don't know how to ask if this person is gay. And I said, well, first of all, you don't have to. just do the test. But, and I said, well, you just ask the same way you ask everybody. You know, you say, are you sexually active, and who do you have sex with? You know, how many sexual partners have you had? You ask the same thing to everybody. And he was taken aback by that. And I asked him later, I said, do you ever ask about sexual orientation or sexual activity? And he said, no.
This is a huge problem still.
And remember, back when I was in training, we didn't understand any of this. There was no discussion of anything other than male and female and heterosexual. There was just no discussion at all. So you've still got a lot of us old people hanging in there who are totally flummoxed by this. I have a niece who I'm not sure what she identifies as, but uses the pronoun they. And her mother, who's my sister, just doesn't understand any of this, but has been very supportive. My own son, I have twin boys. One of my sons is gay, and the last person he told was me. And his reason was he was afraid of losing me. And I go, you know, I'd been with BJ for 15 years by then. So there's so many things that play into whether someone's open about their sexuality and who they're willing to divulge that information to. And being open and allowing it to come out is the best way. But sometimes even then, it's really hard for people.
This is still a problem that we're battling at the VA, because sexual health history is not regularly taken, even though it's our policy that it should be. And you would be surprised by how many 75-year-old male veterans are sexually active with other men. And their doctors have no idea. They might tell me, because I'm leading the support group, or my name is, you know, I'm an LGBT veteran care coordinator. They might call me and say, you're the only one who knows, but please don't put it in my record. And we can't unless they give us permission, because that's another VA policy. But it's just a tremendous problem still.
Online questions?
Yes. Rosa says, first, thanks so much for this discussion. I'm curious if you could talk about less overt discrimination you face for the thank you, you encounter most frequently, and how can you avoid them?
I can speak briefly to that, which is always a challenge for me.
Speaking of my spouse.
The microaggressions that we all encounter on a daily basis, you know, or on a frequent basis, and what do we do about them and how do we respond? I alluded to at least my take on the way I'm choosing to navigate this transition as being that of ambassadorhood, in a way. Whereas, you know, you're interacting with all kinds of different people. You have opted to externalize your gender identity in a performative way, which makes you visually influenced. And that's, you know, that's going to be much more noticeable, much more noticeable. So yeah, occasionally things do come your way that are distasteful or you know, less than affirming. And a lot of it's body language. The times when it does happen in my direct experience it's just body language, an expression. You know, somebody stepping in front of you in a thoroughfare in a store or something like that. Little gestures, little things like that. The amount of energy one chooses to invest into those moments makes all the difference in my personal experience. Whether or not I choose to personalize and take that personally, again, is my choice. or whether, you know, and I've used this metaphor before, when there's shadows, light dispels shadow. So you just, in my view, you decide how much light you bring to the party on a daily basis. And you get to turn those situations around. You're going to be able to control others? No, but you can certainly influence them. You can certainly influence them. So yeah, microaggressions do occur. I think the human race is always going to be rife with imperfection. Whether we're dealing with, you know, with marginalized population or just in the general swim of daily life. I think we all endure them. Whether we choose to comport ourselves with grace and good humor is another matter. Is it always easy? No, it's not. Especially with the kind of emotional flux that I experience with being in the throes of that, you know, pharmaceutical-induced battles.
Anybody else want to speak to that? Should microaggressions?
I think changing forms is a good start. You know, making your forms be inclusive of all minorities and including sexual and gender minorities. So you're not assuming, like you said, that the parents aren't a father or a mother. You're not assuming that you're female or male, that you have some alternative options there. Because it immediately, that's the first thing a patient does, right, is fill out the forms. They even do it before they come. And if they see that the forms are representative of who they are, or at least acknowledging, validating who they are, they're more likely to come. And they're more likely to stay. And they're more likely to listen to your advice and follow your advice, which means that their health will be better. So I think that's the one step.
Okay, I have one more. Understanding that systematic change to build a healthcare environment that is welcoming to the LGBTQ plus community takes time, as it involves education policy and procedural change, among other things. What are some right now take action items that we as an organization can do to build a welcoming environment that is inclusive of the LGBTQ plus community?
Leave this to our medical professionals.
So yes, this is an ever-changing field with new terminology and things that we use every year. So it's something that constantly has to be looked at and addressed. You know, I think the things that people can do right now, well, I tell people it's as easy as wearing a rainbow sticker on your badge. I bought 500 on Amazon for like $10, and I hand them out all over my hospital, and people send me emails asking for them. And so for me, I think as an LGBT person, that makes me feel comfortable where I'm going, where I can see, you know, tiny little rainbow sticker where most people would look at it and say, well, what is that? And I'm like, that for me is a safe place. That tells me a lot about a person, and what if it's a safe place for me to talk about, you know, my fiance who's a male, or is it a safe place for me to talk about how my clinical interests are in LGBT health? I'm a pretty outspoken person, so I usually have issues with that. But still, nonetheless, not everyone is. Not everyone feels comfortable or feels as though that every place is safe for them, or feels that they just don't have the will to defend themselves, especially when they're sick or in pain. So when you're talking about like patients who are admitted to the hospital, making sure that people know the name that the patient uses or the pronouns that the person uses. I'm not sure what your hospital software looks like or anything, but for us, we have Epic and we have SOGI documentation, which allows people to document a person's pronouns, document their preferred name, all that information. So one, they don't have to tell every healthcare provider. And two, it actually creates a safer way to practice medicine, because you then know if a person has the potential of having a child. That is important to know if someone has a uterus, right? Because if you have the physical ability to hold a child, that changes a lot of things medically, of things that we test for, to do, you know, pregnancy urine tests. I've had a lot of patients who are trans women who they're in the emergency room and they're like, okay, but before you get a CT, I need a urine test. I need to do a pregnancy test. I'm like, no, you don't, I'm not pregnant. And they're like, yeah, that's what they all say. You need a pregnancy test. And they're like, I'm telling you, it's not possible. No, it's hospital policy. And it's like, I don't have a uterus, you know? So it's little things like that that we need to look at the way that we go about things and the way that we ask questions to patients too. Some patients find it very affirming and fun to have someone ask them about a urine pregnancy test when they don't have a uterus, but nonetheless, we should still routinely kind of look at patient populations in order to address that better, so.
Thank you. That's all I have.
So I wear a lanyard, rainbow lanyard at work. And a couple weeks ago, a new physician had just started and came up to me because of the rainbow, right? And she was so happy to see it because she's part of the community, and she was so happy to know that someone else worked there. And I said, there's lots of us. But you know, even for other staff, to have that affirming symbol there can make a tremendous difference.
Wow, wonderful.
Yeah. So, there is any relation or rule between the transgender and sexual orientation? So meaning, do I have to assume that trans male will be attracted to female?
Excellent question. Excellent question. I'll field it my way, and then I'm going to bounce the tennis ball back over. They are not the same thing. One's romantic and sexual orientation is related but separate from one's gender identity. Now, bear in mind that comparatively there are very few transgender individuals. You know, the percentage is about 0.5% of the general population, correct?
Yeah,
perhaps 1%.
Yeah, about 1%.
Right, right. So, you know, relatively very few. But one's sexual and romantic orientation is a completely different matter. Are they related by way of brain science? A neuroscientist or sexologist would say yes, they are related. However, they're certainly not the same thing. And it's understandable how often people conflate the two, treat them as if they are the same thing, or you know, at least very close. So I get why there's confusion, but in my case, for example, transition to female or trending female, I'm trans femme, but does that have anything whatsoever to do with where my romantic energy might go? I feel it does not. I feel it does not. Now, somebody else might say something else. Because again, you've met one trans person, all you've done is meet one trans person. You haven't met them all. You haven't met them all. So bounce this back over to you.
So when we were talking about the spectrums, there was a reason why there's a line in between all the different sexual attraction, gender identity, sex assigned at birth. It's because they all work independently. So for instance, I would say in my practice, it's really hard for my patients who are transgender to really even sometimes say what their sexual orientation is. They don't feel that, you know, even if they are female and they are attracted to females, that they are a lesbian. They feel like they might be something else. So what I do in my practice is I ask, do you have any words to describe your sexual orientation? And sometimes people will be like, oh my God, I don't know. And I say, okay, well, who do you have sex with? Or who are you attracted to? And I write that down instead. And sometimes they'll be like, okay, well, I'm attracted to trans men and cis women, but I'm not, you know, and then they go through this whole list, and sometimes it gets confusing. But it's just as confusing for the patient, because the problem with sexual orientation terms is that the majority of them are based off of cisgender relationships. So it's not easy to translate those into relationships where a transgender person or transgender people are involved in. So no, it doesn't mean one thing or the other. So for instance, a trans female person could be sexually attracted to men, they could be sexually attracted to women, trans men, anything in that spectrum. So one does not equal the other. Sure. Yep.
How come sometimes after a person transitions, they change their gender preference or their attraction?
Yeah, their sexual attraction. Yeah. So that
But
definitely.
not always.
Yeah, that definitely can happen. I think that sometimes when a person is affirming their gender, it is a time in their life where they can be very truthful and open about other aspects of their life. And I know many people that, are married and one of their spouses transitions, and then they doesn't matter in the relationship, even though they say, well, I'm not really gay, but, what is this now? Whereas sexual orientation doesn't have as much bearing. But definitely I have seen sometimes where you have a person talk about their gender identity and say, okay, well, I'm this gender identity, but now I'm also attracted to these genders. And I think it's just because there's been an opportunity in their life where they're able to be open and freely talk to people about that. So I know it's definitely an interesting thing that I've seen, but I don't think there's great scientific studies on it yet. I'm waiting for that day.
So again, is it a trans male is lesbian?
What was the question?
Can you call a trans female? She's lesbian, maybe to start with?
She can be lesbian.
If she's attracted to women,
Oh,
then she would
attracted
be
to
a
women
lesbian.
initially?
Yes, so if a transgender woman is attracted to other women, you could call that a lesbian sexual orientation if the person defines their sexual orientation that way. Or just like a trans male who is attracted to other men who might be cisgender could be using the term gay to describe their sexual orientation. And that's why I always ask people about behaviors, because their sexual orientation is not always defined by the words that they use. I have plenty of patients that tell me that they're straight. And to me, straight has a different definition than other people, because then they'll tell me that, okay, well, they're having same-sex sexual relationships, but they're married to a woman, so they're straight. I'm like, well, that really changes the healthcare of that person if they're having sex with both men and women. The word that they use to describe it, oh, nice, isn't helpful to me. And that's why I always ask people who they have sex with. Behaviors is what causes, the different kind of healthcare disparities and things and diseases. So.
I just wanted to comment about labels in general. Just be careful with labels. So when I started, I said I identify as a lesbian. I still do, although now I'm married to someone who's male. So technically, I guess I'm a queer person. I'm in a genderqueer marriage. But my identity is my identity. And so I made an exception when he transitioned to male, but I don't feel like that changes my identity. That messes with people's heads. Okay, even my family, But that's why just be careful with labels. Labels are useful because they help us define things and make sense of the world, but they're not perfect. They can't be perfect because there's always exceptions. So use the label that your patients use. You'll always be safe that way.
I'm going to leave this one alone. Sabina asked a very probing question. Speak to, but there are times when changes do occur, when one's attractions do find themselves in flux. And I credit hormone therapy in part, at least in my direct experience with that progression.
Anybody else?
Well, let's put the wrapper on this, and if anybody has brief closing comments, feel free to take this opportunity.
I think I've said
to
it.
share. Yeah. Great. So let's bring our session to a close. I want to thank everybody again who's here virtually as well as who's here personally and physically for honoring not just those of us on the panel, but the efforts of this hospital and the conscientiousness of this hospital and its efforts to get with what's happening out in the world, and always has been. But just now that it's part of the public conversation, it's wonderful to see Catholic Hospital embracing that and taking steps to, facilitate the best care possible. So we're grateful for that as well.
And Erica, I have one more question for you. If she flubs with a pronoun and a person gets upset, what would be the most caring thing to say then? Just, I'm sorry.
And I'll
Yes.
try harder.
Oh, okay.
Yeah, oops. I'll try harder, and I'm going to keep trying. And bear with me, this is new, but I'm doing my best. That's all you can know, anybody, ever.
Great.
I misgendered my spouse in the beginning. You know, it's learning. Right?
Well, I think it's, for me, basically, well, I really, it's really hard to address some of the questions, though, because like I myself is an example. I mean, I grew up and in the society, they always presented myself as a woman. So anywhere I go, well, I think that's a good thing for me because inside, in my heart and in my mind, I always know that I'm a woman and honestly, I've never been misrepresented though. But there are, in a certain situation, for example, going to the hospital. I was once a patient in this hospital and I had, I undergo the test. And the nurse was just like, when they called my name, because that time I wasn't yet a citizen. So my first name was my original name back when I was in the Philippines. So the approach of the person when they called me, because I was the one who stood up, and she was just, well, I'm looking for this person. So I said, I smiled, and it's actually me. And I was the first one who said it into the nurse, like, look, I am a transgender woman. And, oh, okay, so this is the test that I need to undergo. So I think sometimes we all know that it's quite important to understand to the people like you, that you don't really have that enough knowledge, the education of who we are, how we address people like us. But most of it is there's like, we can control those things. Because if you know how to approach people and you do the same thing, like you have the term of acceptance and understanding, it's very, very easy to deal with. So, I mean, for both of us here, I think maybe some of you are gonna ask, why really these people here? For me, the only thing that I speak out today, because I believe that this hospital could be a family for people like us. And you people could be just like a parents to us in a way that you can comfort, you can understand and recognize us. Because we're talking about healthcare. But at the end of the day, no matter who we are all here to help each other, you. And it's nice, just like Eric. Eric is just like a family to me, It's always there. So it is important for all of us here, you doctors, needs to understand that part. Because honestly, as you said, doctor, it doesn't matter though, like, okay, so what is your relation to this person, they or whatever pronouns. But sometimes being human and understanding that person, your patient itself, is very, very important. Embracing, the person alone. That's very important for us because care is important for people. So yeah, that's it.
I think that's a really good way to end. I agree. Everybody's human. We should take care of each other, and then the world would be a perfect place, right? Mm-hmm. Thank you guys so much for coming, taking time out of your day, and for all of our attendees for taking time to learn. This has been great. I really appreciate it.
Thank you.
Help yourself. Hi, everybody else.
I really went to the restroom without my mask. Oh my God. I was like using this when I was so like a bitch.